what a learned lecture, and I know Dr. Sasahara and all of us are very proud of you. This lecture really epitomizes your contributions and your approach since even before we met each other when you were working on your PhD. You've pointed out some areas for future research because I'm thinking again toward Thrombosis Summit 2010. And one area is biomarkers and to sort of separate these patients. Are there any other clues that you have in mind? And of course you're running and also sit on many advisory boards where new heart failure medications are being developed. Are there any new heart failure medications that might tackle in a combination way the thrombosis problem with problems with the myocardial cell?
Yeah, so prevention. So it goes back to the basics, not smoking, don't have a heart attack in the first place, treating blood pressure in the first place. And that message is getting better and better. I was disappointed with Greg's slide about, or yours, about how infrequent we're already taking the high-risk people. So to treat a lower-risk person, we need more data. And I was very bullish on the biomarkers. If we can increase our knowledge of risk stratification. On the other side, I'm a little disappointed that Christian didn't tell us more about identifying who the people are who are more likely to bleed. And I think the challenge to these databases that have 20, 30,000 people, some bled, some didn't, to come back to us. So if we can do a better job of who's at risk for the event, then I can be that perfect doctor where I have only those who will have a stroke and not those who will bleed.
And what about diastolic dysfunction heart failure? You talked about preserved ejection fraction. And I guess over the last 35 years, we've become aware you can have severe heart failure with diastolic dysfunction too. Those the patients didn't appear to be from what the slides you presented, but what sort of risk are patients at with diastolic dysfunction?
So I showed you the CHARM data. There are really only 3 trials in this field. There's CHARM, I-preserved, and a plug for the American Heart. We too are presenting a late breaker called TopCat, where we use spironolactone in people with preserved systolic function heart failure. Just for the group who's concentrating on thrombosis, the reason you hear preserved systolic function and you don't hear diastolic dysfunction is because when you find these people, we don't have a diastolic index that says it's this person. So we use the ejection fraction. And I was trying to carefully point out they are as higher risk of having a stroke and thrombotic event as if they have symptomatic heart failure. So in your CHAD score, it doesn't say what's the ejection fraction, except low EF without symptoms also gets you a point.
We have time for a question or two for Dr. Pfeffer. Mark, thank you very much.